Okay, welcome back. Welcome back. It's time to proceed with our next keynote speaker. Please make your way back to your seat. So I have the pleasure of introducing our next keynote speaker, Dr. Robert Smith. Dr. Smith is a cancer epidemiologist and Senior Vice President of Early Cancer Detection Science at the American Cancer Society. For most of his tenure at the ACS, he's led the development of cancer screening guidelines and has been active in research on the effectiveness of cancer screening, utilization of cancer screening, improving the quality care of cancer screening, and new screening technologies. Dr. Smith and his team focus on ensuring that ACS cancer screening guidelines rely on the best scientific evidence, meet high international standards of quality, and have the potential and aim to significantly reduce the burden of cancer. He and his team also track technical advances in screening technology and new approaches to early cancer detection so that ACS can provide guidance on these new tests to clinicians and to the public. Please help me welcome Dr. Robert Smith.
So, good morning. Everybody can hear me all right? Yeah, good. All right, thank you. So I'd like to thank the organizers for the invitation. I've always enjoyed coming back to Iowa and having an opportunity to speak on issues relating to cancer. The first two presentations were outstanding. I like to say it, I think there'll be hard acts to follow. I enjoyed listening to Dr. Charlton talk about personal decisions that we can make, to improve our health. And I got in a little bit late last night and I needed to get something to eat and drink. And so instead of getting a hamburger and a beer and eating them alone in my room, I walked down the street to, as I described to my wife, a charming Australian restaurant. Who can guess? She couldn't. And she said, an Australian restaurant? I said, well, we have one in Atlanta. And she says, oh. But as far as, the social part, I'm reminded again at the bar how different Iowa is than Atlanta, Georgia, where hardly anybody from the South lives anymore. Because everybody who walked in and was directed to the bar because they were alone said, hi, how are you? So Iowa's a very friendly place. All right, so new developments in cancer screening, no disclosures. So this is the outline. I think for when you have an hour-long talk, it's good to have an outline. It might even be good to have a countdown of the number of slides that are remaining. But this is what we're going to talk about. And I had some recommendations from the colleagues and the organizers about topics to touch on. So this is a pamphlet that was written by Wilson and Junger for the WHO in 1968. Screening was just getting started. Mainly cervical cancer screening, but there was interest in finding strategies to find other cancers earlier. People at this point, we had pretty much understood that cancer is a progressive disease. If you can find it earlier in its natural history, outcomes are likely to be better. At the same time, we knew that there are biases that could trick us in determining whether outcomes are better. So Wilson and Junger wrote this book, this Principles and Practice of Screening for Disease. I think it is probably the most widely cited work in cancer screening that no one has ever read because you can't really get a copy of it. But the principles are well established and they're commonly cited. And as you can see, the disease needs to be an important part of morbidity, disability, and mortality. Its natural history has to be well understood. The other features are bolded here. It's essentially a blueprint for what you have to confirm in order to have confidence that you can effectively and safely screen the population. And I'm with Dr. Rothmel on this because the studies that we have to do to show the efficacy of cancer screening aren't quick. They take a long time to get started. They take a long time to run. They take a long time to follow up. 15 to 20 years, in fact, is not uncommon. Now, what we have to understand also about cancer screening is that the purpose of cancer screening is to reduce the incidence rate of advanced disease. People say oftentimes it's to find small cancers. Well, yes, usually in the natural history of disease, they're smaller, but some small cancers may really not be that life-threatening. The goal ultimately is to reduce the incidence of the cancers that will progress and actually become life-threatening. And for some of our cancers, when we do that, we can not only reduce mortality, but we can prevent the disease from occurring as well, cervical cancer and colorectal cancer specifically. So cancer screening is also controversial, and I've been doing this for many, many years, and some of these controversies just don't seem to go away. And so this one is one of the ones that they suggested that I talk about. It was a recent report that came out as to whether or not we should measure the effectiveness of cancer screening not on the basis of disease-specific mortality, but on the basis of whether cancer screening reduces your risk of dying from anything at all. Now, this is not new. This issue has been around for about 25 years, and it keeps rearing its head. So let me walk you through this. It's going to be exciting, I can tell you. All right, this was the recent article. It was published in JAMA Internal Medicine by Brettenhauer and colleagues. And he said that cancer screening tests are promoted to save life by increasing longevity. Now, I thought, well, that's kind of news to me, but okay. And it's unknown whether people will live longer with commonly used cancer screening tests. So it's a whole issue. If you get screened for cancer, you're going to live longer. And in fact, they said that the findings of the research showed that that just was not true. Now, this is the main table. It's a little bit busy, but if you look to the right, what you'll see is that the relative risks of all-cause mortality in all the collection of these trials in the meta-analysis are 1. I mean, basically no difference. And in terms of life years gained, they show next to none. So essentially, the idea is that whether you get screened for cancer or not, you're not going to live any longer, and you're not going to gain any life years. You're not going to avoid any premature mortality. Now, that seems kind of strange to me. It probably seems strange to you, but it was remarkable about how many people pounced on this and said, well, the veneer has just been lifted. As it turns out, and as the author said, the slogan did not hold up. Cancer screening saves lives did not hold up. And the editor of JAMA Internal Medicine said, despite the popular tagline, most cancer screening does not save lives. All right, so let's talk about that. All right, first of all, I've worked for the American Cancer Society almost 33 years. I do not recall us ever saying, if you get screened for cancer, you'll live long. Get screened for cancer, it'll increase longevity. We don't say that. We do say it saves lives, and we say that because we have the data to show that, in fact, it does. Now, the randomized trials that the investigators chose were, I think the epidemiological term is cherry-picked. There was really no logic for which ones were included or not included, other than they happened to have evaluated all-cause mortality, which we showed 25 years ago was kind of a waste of time. The follow-up was too short to actually measure the ultimate benefit of screening. So all of these trials were based upon the first report that they had reported on a mortality difference. And instead of actually measuring the outcome of people who got screened, which we don't do in trials, we use what's called an intention to treat analysis. So we're comparing people who are invited to screening versus people who were not invited to screening. And that's the way we do randomized controlled trials, but it dilutes the effect of the screening because many people do not show up for screening, and many people in the control group, after a while, start getting it on their own. So the effect is diluted. The main thing is that none of these trials had the statistical power to measure a difference between everything you might die from, in addition to the disease you're being screened for, compared to not. And the reason that we do not design trials to measure all-cause mortality because they would be too expensive, too unwieldy, and they would take too long to complete enrollment, screening rounds, and follow-up. It's just actually impossible. And all-cause mortality, as you would expect, is always going to be dominated by common causes of death unrelated to the cancer that you're screening for. And I'll show you what I mean by that in a minute. So in other words, there are some deaths that might be related to cancer screening. They would be deaths associated with diagnosis and treatment. You do want to know about those. And if you only focus on disease-specific mortality, you won't have a chance to see whether, for example, poorly targeted radiation to the breast was causing cardiovascular deaths. Now, the conceptual problem with the article, the study, is should screening for a particular disease be measured against its contribution to keep you from dying from everything? And I think everyone in this room would probably say, how would it do that? How is getting screened for breast cancer going to prevent you from dying from kidney cancer or a car crash or any number of the other things that you have a possibility of dying for in your lifetime? The analysis focusing on a single cause of death against all causes of death rather than the contribution of achieving longevity by better avoiding years of life lost is what makes more sense. And when systematic reviews, and the task force commonly does this, and every time we review their drafts, we say, stop doing this. When they conclude that a reduction in cancer mortality was observed, but no reduction in all-cause mortality was observed, their message implies a compression of mortality. In other words, you didn't die from this, but you're still going to die from that, so almost what's the point? And if you think of average longevity, it's hard not to make that conclusion. You all remember Sanford and Son? His son would always be ragging on him about living a more healthy lifestyle. And finally, he had this outburst, and he says, health nuts are going to feel stupid someday lying in the hospital, dying from nothing. It always resonated with me. The point is that we have an expected longevity, and we measure whether or not you can achieve that. We sort of think you might achieve that based upon all the things that you might die from and all the things you can avoid. Now, in terms of actually measuring all-cause mortality, here's an exercise that just shows you the kind of samples that you would need. If you have a particular disease X, it's responsible for 5% of all deaths in the target population over the next 15 years, but there's an intervention that can prevent 70% of the deaths from X. And if 3% of the target population will die from X over the next 15 years, if you have all-cause mortality as the endpoint, you would need to randomize 1,095,000 individuals between an intervention and no intervention groups to have 90% power to show a benefit. If you're just studying whether you can reduce deaths from X, you only need about 41,000 individuals. It's impossible to measure a benefit in all-cause mortality. It's an inefficient and irrelevant endpoint. As I said earlier, is there ever a reason to look at all-cause mortality? Yes, you want to make sure, in fact, that you're not harming patients with your diagnostic tests and your treatment. And so you do look at all cause of deaths for those deaths that could possibly be related to the disease in question. But measuring a benefit against all of them is just impractical. All right, now as you can see, with a small fraction, not small actually, but a smaller fraction of all the deaths in the United States each year are due to malignant neoplasm. And I'm going to show you the National Vital Statistics reports just to give you an impression of the complexity of what we're dealing with here. This is the list of 113 selected causes of death. This is great reading, by the way. Here is a list of almost 3.5 million deaths that occur each year, compressed for your visual pleasure. And you can see how what a busy thing all causes of deaths are. Some of these we cannot avoid. Some of these we have no chances of avoiding. Some of these we do have a chance of avoiding. And that's what brings me to the whole issue of life expectancy and premature mortality. So you can see here from birth to life expectancy for women from birth is 80.2 years from age 65. If you make it to age 65, it's about 85 and a half years. Now, the lifetime risk of dying of something is 1. You understand this. We're all going to die of something. And there is no avoiding this. This is a breakthrough. We just learned this. So the goal is not to avoid death per se, but to avoid dying early. That's what the emphasis is. That's what the better health habits that were described this morning help us to do. They help us to live longer and healthier, if we're lucky. Okay. Now, I didn't get a chance to show you, and I don't know why it's doing this, but guys, this is the sum total. In other words, this breaks down in terms of the number of years of life lost for each of these cancers. And what I hope to show you, and I'm not sure why it's not showing up, is what those averages are. So if you look at the individual cancers, they tend to run on an average of like 14, 15, 18 years of life lost per person who dies from cancer. It's substantial, measured against the average longevity at the time you're born and what we can project for you. So that, in fact, when you are screened for cancer, and if you have the good fortune of finding your cancer early, you can avoid a premature death. That gives you the opportunity to potentially live to the end of the projected longevity if you don't happen to die of something else, or it helps you live beyond that average projected end of longevity. So as I point out here, it makes no sense to judge a single preventive health benefit as having no value if it doesn't prevent all-cause death or extend longevity past the average longevity in low-powered studies. Now, what I'll also show you right now is that the idea that it will not extend longevity or help you to live longer also is not true. But what you have to do is you have to compare the deaths from the disease in question against avoiding the death from the disease in question versus not. Now, in this study we did, and I was telling the truth when I said this goes back about 25 years. We published a study 22 years ago looking at deaths from all causes among breast cancer cases. And in a conservative analysis of deaths from all causes from breast cancer cases at 20 years after the start of the trial revealed a 13% reduction in all-cause mortality. 13% reduction in all-cause mortality. Now, why is that? Breast cancer is a leading cause of death from all causes in women. You know, about this time, it accounted for a little over 3% of all deaths. Almost, 1 in 33 deaths among women. And what we also saw, and we looked at this with the UK data, is that breast cancer accounted for 17, 15, and 8% respectively of the deaths in women in their 40s, 50s, and 60s. And because younger women it's a growing cause of death in younger women, and they're not likely to die of many other causes, it represented a larger fraction of deaths, even though the effectiveness of breast cancer screening in very young women was not as great as it is for women 50 to 59 and 60 to 69. So even a modest reduction in breast cancer mortality actually was going to prevent you from dying technically of everything, measured statistically. So those that develop breast cancer and had attended screening would not only reduce their risk of dying from breast cancer, but statistically against all causes of death, they reduce their risk of dying from everything. So I just want to reassure you, when these kinds of things come up, that just basically throw the whole concept of cancer screening under the bus, it's generally a methodologic issue, and it's generally not true. What you've learned about the value of cancer screening remains true today. It, in fact, can measurably, reduce your risk of dying, and it can contribute to you actually living longer. Okay, next topic. Why do guidelines differ? So you do sort of get this sense of how come the guidelines are different? Presumably, they're looking at the same data. Leading organizations, the Preventive Services Task Force, the American Cancer Society, shouldn't the guidelines be similar? Well, one would think. Okay, you mentioned that lag. All right, so what are these differences? Now, I'm talking about the difference between the American Cancer Society and the Preventive Services Task Force, which are the differences in guidelines that I think that most commonly come to people's minds. So the Preventive Services Task Force has a well-defined approach to cancer screening guidelines and everything. Keep in mind, the task force covers all preventive services. There's probably close to 100 of them that they do updates on a periodic basis. And to avoid bias, and it's really quite sensible, I think, they have non-specialist experts deliberating over the evidence and making the recommendations. The American Cancer Society has experts with some specialty knowledge in cancer and screening, because we find that actually works better. If somebody earns their living, say, screening for breast cancer, then they cannot be part of the guideline panel for that particular guideline. The systematic reviews are done by evidence-based centers. The American Cancer Society has brought our systematic reviews in-house because we find that the quality is better. And in fact, when we use third parties to do our systematic reviews, we find that we need a lot of back and forth with them to have them produce a review that is more useful for the question we're trying to answer, simply because they aren't experts in evaluating cancer screening. In terms of evidence, the task force prioritizes randomized controlled trials to the exclusion of observational studies. They also rely on modeling. But once you do a trial, the likelihood of doing a second trial and a third trial gets lower and lower and lower. You also would have a hard time actually populating that trial. Once you know that cancer screening works, people are not likely to be randomized to a no screening group. Now, sometimes when we have new technology, we can randomize in a way that doesn't really pose any risk to patients, and you can, do both tests, so you can compare them in a way that actually can give you good information. But by and large, we do a trial to demonstrate the efficacy of cancer screening, and then we're going to answer all the remaining questions about that particular cancer screening through observational studies, and the American Cancer Society relies on them a lot. Commissioning special studies, the task force principally does reviews of the evidence and modeling studies, whereas the American Cancer Society has found itself commissioning studies to fill gaps in the evidence base where we can actually address a question as opposed to saying the trials never answered that one. Grade evidence and recommendations, we both do that. In terms of looking at disease burden, the American Cancer Society tends to be more granular, and I'll give you a good example of that. When we recommended that screening for all women for breast cancer should start at age 45, all of you are familiar about the argument that never will go away as to whether screening is more effective in women 50 and older versus women 40 and 49. Those are pretty large populations of women, and the most relevant groups are 40 to 49 and 50 to 59. But are they that relevant? This is a period when women undergo the menopause. If you break those age groups into 5-year age groups, you will find that women 45 to 49 and women 50 to 54 look very similar. That's 22 million women. The burden of disease is similar on an annual basis. Years of life lost is similar. Number of deaths is similar. Incidence rates are more closely similar. And 40 to 49 looks much worse than 50 to 59 because of the 40 to 44s and the 55 to 59s. We said you can hardly explain to any woman 45 to 49 why she shouldn't get screening and women 50 to 54 should. So getting down and granular on disease burden and especially premature mortality indicators of years of life lost, I think has proved very useful for us. In terms of benefits and harms, frankly, the task force is more concerned with the harm side of the benefit and harm balance, and the ACS is more concerned with the benefits on the benefit and harm balance. You can make arguments for both, but the large fraction of harms in breast cancer screening is being recalled for further evaluation. And we just don't think that that's a harm that should tilt the guideline in the direction of less reduction in mortality. We have different cultures. All guideline groups operate with different cultures, especially some of the professional society groups. So these can lead to different judgments. And guidelines updates are not synced. So sometimes people are thinking, well, you're looking at the same data. Why are the guidelines different? Well, you're not looking at the same data. If you're updating your guidelines every 5 years, you may have updated them the year before a study that would lead you to change the guidelines came out. Guideline updates are arduous, and it doesn't mean that you're going to make that change necessarily before the next scheduled update occurs. So colorectal cancer is a very good example. The American Cancer Society changed the recommendations to begin screening from 50 to 45 in 2018. The task force had just updated their guidelines in 2016, and the paper on the birth cohort effects that was resulting in rising incidence in colorectal cancer in younger populations that was carried forward, making 45 the new 50 in effect based on the age-specific incidence rate, came out a year after the task force had finished their update. So we petitioned them, suggested that they might want to update the guideline earlier, but they have a schedule of things to update. So they said they just really couldn't. That accounted for that difference until 2021, when the task force also dropped the age to start screening to 45. All of you are thinking there's got to be a better way to do this, and there is, if you can do it. But the American Cancer Society is. We are moving to a living guideline model where once we've established a foundation of systematic evidence reviews for all of the cancers we currently recommend screening, we will move to a living guideline for each one of them, which means that we will update the guideline whenever new data warrant updating the guideline. We'll be monitoring it on an ongoing basis, and it's a little bit like you either tear the whole house down and build it up again, or you just remodel one room. So if we have an opportunity to make a change because one needs to be changed, we can do it in a fairly short order. All right, we're going to move now. What's new is going to now go to the specific issues on the cancer screening, starting with breast. So it's useful, I think, to show you what the trend has been in screening. And keep in mind that these reports from the Behavioral Risk Factor Surveillance System, we all rely on these in the National Health Interview Survey, they're self-reports. So they do tend to be inflated. So we are not doing as well as we think we are on population-based screening. There's obviously some pretty significant inflation here, and it's been pretty flat. So, and those are the rates without going over them too much. These are the guidelines right now for the task force in the American Cancer Society. Recently, the task force began to recommend screening in the 40s again, and recommend biannual screening for all women ages 40 to 74, whereas the American Cancer Society has a hybrid model where women 40 to 44 can choose to begin screening if they want at any of those ages, but we recommend that everybody be screening at the age of 45, and that women 40 to 54 should undergo annual screening simply because results are better with annual screening compared with biannual screening. Now, in the absence of a system of screening, what we do is we get a pattern of screening that looks like this. As you can see, this is from the Breast Cancer Surveillance Consortium, which has benefited from NCI funding for since the early 90s, which has been great. I mean, I don't know where we would be without it. And I was part of the team that wrote the legislation for the MQSA, Mammography Quality Standards Act, that led to putting a line item in for a surveillance program for breast cancer screening. So it's been terrific. It's produced a fabulous body of research. But what you can see here is that roughly about a little over half the population gets screened within 11 to 14 months. These data actually look as if most women intend to get annual screening. But what happens is that life intervenes, right? Something comes up. You can't make your appointment. You forgot you had your appointment. But what happens is that not all women get regular screening. And that is a concern, because as hard as any woman in this audience can tell you, if you've missed your exam, it may be hard to get another one scheduled very quickly. And you may miss that one, or at any rate, things come up. Well, what are the consequences of that? And we decided to do this analysis, and I didn't think that they were actually going to be that great. If you get screened fairly regularly, you're probably carry some reasonable protection. We're fortunate with Swedish data to be able to look at what happens when women develop breast cancer and did not get screened in the year that their breast cancer was diagnosed. So we looked at a base examination, and then we looked at whether or not women got the next examination and not the one after, or whether they didn't get the next one but did get the one after, so that the breast cancer has had some time to grow when in fact women were not being screened. So if you look at the top two trends here, the green trend are women who attended all screening examinations. They had 50% lower risk of dying compared to women who missed 2 examinations consecutively. These are women who develop breast cancer. Keep in mind that most women miss examinations. They don't have breast cancer. The consequences, there are none. For women who didn't get the next one or got the next one but didn't get the one after, these women were actually 23 or 30% more likely to die of breast cancer. And it's simply because if these women had aggressive cancers, they had a long time to grow and progress and become advanced when these women were asymptomatic, or perhaps developed the cancer with symptoms during this interval when they'd missed their mammogram. So it is very important, in fact, to do everything you can to keep that appointment. When I presented these data at the RSNA the night before, you're in your hotel room, and I'm thinking, I wonder if we really talk about this in our educational materials. So I'm getting on the internet, I'm looking at Komen, American Cancer Society, I'm looking at all of the organizations that provide education to women about breast cancer screening. It's very thorough, it's impressive. Not one of us said simply, breast cancer screening works best when it's done regularly. If you believe in getting regular mammograms, you believe in that, you've always done it. It may not seem like such a big deal if you ever miss one. The important, and it's not if you don't have breast cancer. If you do have breast cancer, it can be a big deal. So we really have got to educate the public more about the importance of regular screening. Breast density. This is timely because the FDA just put in reporting requirements for density on mammography reports. This has been going on for a long time, ever since, over 10 years that we started having state legislation to actually require reporting breast density. Nancy Capella from Connecticut, got that started when she was diagnosed with advanced breast cancer. And her doctor said, and she said, how is this possible? And he says, well, you have dense breasts. And she thought, that's the first I've ever heard of that. And if I did and other women do, they need to know. So density is associated with increased risk of breast cancer, but not all women with significant mammographic breast density are at increased risk. It's associated with lower sensitivity and specificity of mammography. And due to masking, in other words, the density hiding a breast cancer that otherwise might be picked up, that is associated with an increased risk of being diagnosed with an advanced cancer, even if you weren't at greater risk of developing breast cancer. So we've known these facts for many years, but we have not really had a strategy to deal with it. So what the FDA has done is essentially said women need to be told about this density in a sort of a dichotomy. Your breast is not dense, or your breast is dense. Now, I have a bit of a problem with this because it's not really a yes or no, issue. These 4 categories that are going to be reported on every woman's mammography report, and this is different than the letter that she would get about her findings, break density into 4 categories, and this represents the dominant groups, of course. It's about 50-50, but you can see that the scattered fibroglandular density accounts for about 40% of women, and the heterogeneously dense breast accounts for about 40% of women, and the extremely dense breast counts for about 10% of women. If you have extremely dense breast, mammography does not work that well for you. It doesn't mean that some of the breast isn't interpretable, but quite a lot of it is not. And this is where you probably definitely would benefit from supplemental imaging. Some women in the C category definitely would benefit from supplemental imaging. And there are some women actually in the B category for which supplemental imaging would be somewhat useful. And I think this is information that is lost in the new FDA's approach, and it's something that we need. Now, what have we been doing in these areas? Well, there's no perfect test for dealing with this. Mammography has moderate sensitivity, and these are the pros and cons about all of these tests. Ultrasound is what we've commonly been using, but it's hugely operator dependent. It takes a lot of time. It's not reimbursed well, and for all of those things, it's not popular among doctors. Molecular breast imaging is looking like a very good and relatively low-cost solution because you can adapt any mammography unit to do that. MRI is pretty spectacular. When you do abbreviated MRI, it can be done at a very low cost, but a lot of hospitals don't want to do abbreviated MRI because they can charge a lot more for a full protocol MRI. Let's get to the next problem. Not every center in the country, in fact, most centers in the country, do not have all of these options. So we have a challenge without a very clear solution. And I think even to this day, it's not clear how we would address this in a guideline, which is what we're challenged to do right now with the American Cancer Society as we update our breast cancer screening guidelines. How are we going to provide guidance about dealing with breast density? And I think that one answer that we probably already have is that we're not going to succeed with a one-size-fits-all. But where I think there could be some new direction is with artificial intelligence, and we touched on this morning. So artificial intelligence right now is being targeted at interpretive domains. That means the lesion detection and diagnosis, triage, and density assessment. It's essentially evaluating the image and showing some consistency in how it labels those patterns. But it's also being effectively used in the non-interpretive domains where it can actually learn to predict risk. And we're finding, in fact, that it's providing a solution to risk prediction for minority women where we don't have a rich database to look at their outcomes according to conventional risk factors. I have to say, it's really pretty impressive. And you have the traditional machine learning type of AI, and then you have the deep learning, which also is showing really quite impressive results, especially when you might be inclined to call a patient result normal, when in fact the machine would say it's really not normal. This is an example for a 76-year-old woman who had 2 lesions on the MM and the CC view that had assigned different level of risks, and it turned out that she did have breast cancer. Radiologists are reporting that this is such a more effective tool than the earlier CAD that was used for many years because it provides essentially a second reader. And what we all know also is that depending upon the time of the day and the volume of examinations you've been reading, you're not necessarily always going to be at the top of your game. And having this a synthetic separate reader working with you can go a long way, I think, to both avoiding recalls that aren't necessary and also identifying women at higher risk that you might otherwise overlook. Now, what I was getting at just a second ago is that we know that not every woman with a dense breast is at high risk. We also know that women without significant breast density may be at high risk based upon the parenchymal patterns of her breast. It is not something that would be particularly obvious. But the AI tools are actually doing a nice job of showing, in fact, who needs to be triaged for MR, regardless of just what the human reader might conclude based upon looking at that breast. This is a nice study that was reported recently from the, it's called the Screen Trust MRI trial, and it's done in Europe. And what they observed here is that among 88,000 women screened, the tool triaged women to MRI where they detected 64 breast cancers per 1,000 women who were referred, with a very, very strong positive predictive value. This actually might be a strategy that is going to address who needs to get supplemental imaging and who does not. And it would certainly be much more cost effective, and we would just simply have to make sure that everybody had these AI tools that they could use to reconcile this challenge of how to ensure that supplemental imaging gets done when it's needed. Now, the task force has updated their recommendation statement to include women ages 40 to 49. They recommended biannual screening. The argument is that, in fact, that there's been an increase in breast cancer incidence in the younger age group, and that this is going to remove or somewhat reduce disparities in the black-white mortality rate for breast cancer. When you look at these data, and you can look at the estimated percentage mortality reduction, you don't see a lot of difference between the different strategies, which is one of the reasons that the task force settled on biannual screening for the ages 40 to 49. This, from a modeling standpoint, is puzzling to me, and I'm not sure why there are such small differences, because we have seen stronger differences in empirical studies with more screening, and of course with more screening you get more callbacks, which is something that concerns the task force. But this is somewhat surprising. At any rate, what we saw when we updated our guidelines, and we used the Breast Cancer Surveillance Consortium data, and we wanted to get at this issue that, all right, so we don't have a head-to-head trial with annual screening and biannual screening, but we have this rich observational database with thousands of breast cancers, many, many thousands of women, actually millions of women who've undergone screening examinations. And so we ought to be able to see what the outcomes were among women diagnosed with breast cancer based upon how recent their last mammogram was. So for women that are undergoing annual screening, what is the distribution of tumor characteristics and stage compared to women who are going biannual screening, and look at that by age, 40 to 49, 50 to 59, and so on. But we also looked at it by the menopause. All right, so fasten your seatbelts. All right, so in bold are the statistically significant differences. So look at the top of the graph. We don't see any bold relative risks when we look at these differences by age. I'm looking at this the first time and I'm thinking, what's going on? Our imaging has gotten so much better compared to the old screen film mammograms that we've overcome this challenge of density, and maybe even by improving sensitivity, we've overcome the challenge of tumor growth rates, because this whole screen annually 40 to 49 and biannually 50 to 59 isn't really playing out. But then we looked at the menopause. The menopause in this study was simply measured by asking a woman, have you had a menstrual period in the past year? Okay, so we know that the women know this, most men don't. It's not like the menopause happens and then you're done. It's a gradual process. So even, looking at it this way, when we looked at it by the menopause, we saw, just by this one simple indicator, everything sort of lit up the way we expected it would. That women who were premenopausal and got screened every year had better outcomes than women who had screening every other year. Women who got screened every other year in a 2-year interval were much more likely to be diagnosed with advanced breast cancer than women who got annual screening. All right. Now, why was that? I'm not expecting you to answer this. I'm just setting up the answer. So a lot of women who've gone through their menopause before the age of 50 and a lot of women who haven't gone through their menopause after the age of 50. So it washed the effect out. And we looked at it just by the menopause. We saw it. Primary care providers on our guideline development group says it's a lot of trouble to keep asking women whether they've been through their menopause. Since most women are through the menopause by the age of 55, let's just set that interval, 40 to 55, annual screening. Annual screening after the age of 55 if you would prefer that, but you could safely go to biannual screening after the age of 55 if you would prefer. I think this is a very nice use, and hats off to the NCI and the Breast Cancer Surveillance Consortium, because we wouldn't have these data if it weren't for them. Cervical cancer screening. I think, okay, and here's our trends, yes. Cervical cancer screening has been declining a bit. This is a concern. I'm not sure exactly why. It may be a residual from the pandemic, but it's something that we have to fix. Now, the cervical cancer guidelines have been evolving over time, for a long time, and this has been really great because it means that the more we learned about HPV, the more we get away from just sexual behavior-driven guidelines that, said that you should start screening the first year after intercourse and so on and so on. So the age to start screening has been steadily moving up. The task force still recommends 21, but I expect that they will join the American Cancer Society the next time they update their guidelines and start at age 25. We place great priority on HPV alone testing compared to co-testing, both which can be done every 5 years. And if you are only getting a cytology, that should be done every 3 years. We also say that women can stop screening at the age of 65 if they have a history of technically satisfactory normal screening tests in the past 10 years. Now, you can stop at age 65 if you fulfill this exit criteria, which are pretty straightforward. If you don't fulfill them, then you have to still keep screening. But there's a real advantage to stopping screening at age 65, just because it's harder to get an accurate test result. It's more uncomfortable. And many women would really love to stop screening at age 65 if they could. Now, what we find, though, is that most women do not meet this exit criteria, not for any of these other reasons that I just showed you, but mainly they just have not been having recent cervical cancer screening. So it's really important that we do a better job of this. And I'm hoping self-collection is going to help with this, because many women who are no longer involved in their reproduction are probably not seeing an OBGYN as often to provide this opportunity. I want to show you a little bit of data about HPV vaccination. It's really terrific. So what we see here is that vaccine-type infections among U.S. women are declining pretty rapidly in the cohorts that have been vaccinated. This is great news, as you can see, and it's getting better with time. We see that there's a dramatic decrease in cervical precancer in the ages 18 to 24 from 2008 to 2016. Big drop. And again, it's a function of the immunity that's provided by routine vaccination and a near elimination of cervical cancer before the age of 30, which again is great news. I mean, we've had this opportunity. The combination of screening and vaccination is steadily giving us the opportunity to reduce the burden of cervical disease. Now, the FDA has approved self-collection, also called self-sampling, but it until the SHIP trial is done, it's likely that it's not going to be changed, and it is only approved to be done in the doctor's office. So women will not have to have a speculum examination, but they can do self-collection. And I think it's going to lead eventually to the opportunity to widen access to self-collection, which is going to be very important to achieve screening in rural areas where it's hard to get to screening in minority groups and new immigrants who may be averse to a speculative examination, all of the reasons that women may give for not wanting to get regularly screened have been overcome with self-sampling in many settings. All right, colorectal cancer screening. These are the trends. The screening rates are actually pretty good right now, but as I'm going to show you, we are slow to get started with screening. These are the recommendations right now. We mainly start at age 45. You know, we have a long list of options for colorectal cancer screening. The rates are actually pretty good and actually accumulated. We saw some increase when the American Cancer Society National Colorectal Cancer Roundtable had the 80% by 2018 campaign. What we have here is a test for anybody. I mean, in other words, what we find the remarkable thing is there are people who say, I would never do that test, but I'll do this one, and vice versa. The important, as with every other aspect of cancer screening, is to do it regularly. A big concern, however, is that the recommendations now start at the age of 45, and we've seen very slow uptake of screening beginning at age 45. We still see slow uptake of screening between the ages of 50 and 54. And the problem is that when we delay screening in the presence of this birth cohort effect of rising incidence that is carrying over well past the age of 50, this is like a tsunami effect because this effect is getting stronger as these cohorts pass through time. We're beginning to see an increase in regional disease. It's not declining. When we look at the rates for adults 50 and older, incidence and deaths are going down. But that aggregate rate masks an increase in mortality and an increase in advanced disease before the age of 60. And the campaign really now has to be start screening as soon as the guidelines recommend it. Now, in terms of what's new, we have 3 new tests this year. Actually, one test is not new. Cologuard Plus is a next-generation multi-target stool test. It's been around. For those of you who watch CNN, you see this little walking box every other night, and we have to thank Exact Science for being the only organization that's promoting colorectal cancer screening on national TV. But what's interesting right now is that we have a new multi-target test that's called ColoSense. It's an RNA test as opposed to a DNA test. And we have a blood test, SHIELD. It's produced by Guardant. It's a cell-free DNA test. Now, here's what's interesting. I'll draw your attention to this. So just look to the right. You can see these performance characteristics. So for the two multi-target DNA tests and RNA tests, they have really quite similar performance. They have very good sensitivity for colorectal cancer, acceptable sensitivity for advanced adenomas, reasonable specificity, but with colorectal cancer screening, a positive test like this sends you to colonoscopy, and if you're normal, you don't have to be screened for another 10 years. It's a false positive that actually has a give back. The blood-based test is also approved by the FDA, and it's got acceptable sensitivity for colorectal cancer, about 83%. But it has terrible performance for advanced adenomas. This is not a test that we can expect to prevent much colorectal cancer. And this poses a bit of a challenge for us. It's approved by the FDA. It's not on any organization's guidelines, and I can't tell you whether it ever will be. That doesn't mean that people can't use it once it's FDA approved, and it's approved. It's not just cleared, it's approved, it's available, and you could get it. A question you have to ask yourself, because we can be really self-righteous about these guidelines, is it better to get an increase in screening of 20 or 25% as a function of point of care service, where the physician says, you're way overdue to be screened for colorectal cancer. There's this new test. How about if you just get this test today? Go down the hall, we'll draw your blood. It can find colorectal cancer if you have it. Presumably you would have a more thorough decision and discussion about its strengths and weaknesses, but patients would get screened. We're confronting this kind of a question for the first time. There was a test that was previously approved. There was a methylated septin-9, but it never made it on anybody's guidelines, and it's still available, but no one is using it. For that very same reason. It had very, very poor performance in actually preventing colorectal cancer. All right, lung cancer screening. All right, these are the guidelines. The guidelines have evolved from the original NLST recommendations. In 2021, the task force dropped the age from 55 to 50, dropped the PAC years from 30 to 20, but retained years since quit. So in other words, once a person who has quit smoking, has been free of smoking for 15 years, they are no longer eligible for lung cancer screening. Now, the American Cancer Society changed its guidelines pretty much consistent with the task force, except we eliminated any consideration of years since quit. So we have said that years since quit is not a consideration, and I will show you why. But it's important, I think, right now to just very quickly show you that we have, according to the latest behavioral risk factor surveillance system data, we're up to about 18% screening. For the longest time, we've been saying only about 5% of people have been screened. That's not the case anymore. It's only about 18%. We're feeling elated, but it's a very small number. You know, and we have got to do much better. But one of the reasons we're not doing particularly well is that a lot of people who are eligible for lung cancer screening don't have health insurance. We see the usual thing where if they don't have a usual source of care, they're not likely to get a referral for lung cancer screening. And what we have seen is that among Black adults, they don't tend to start screening until they're 65 because they haven't had insurance. And once they have Medicare, then they can start. And this was a paper written by Michael Halpern about 30 years ago. And when we read this paper, most people, the conclusions they drew is, look at how protective stopping smoking is at a young age in terms of your eventual lung cancer risk. It's a very strong take-home message that the earlier you can get someone to stop smoking, the lower their continuing risk of lung cancer will be. It's laid out very clearly. You can compare the current person smoking with those who quit in their 60s, those who quit in their 50s. What was not really didn't really resonate with people here is how much your risk continued to increase after you stop smoking if you stop smoking at an older age. I imagine most people in this room think you stop smoking, your risk goes down. And it's the most important thing you can do if you smoke is to stop smoking. But your risk goes down relative to a person who continues to smoke. And what we haven't really realized is how high your continuing risk remains. We didn't realize it when we issued our first guidelines in 2013. They were the same as everybody else's. But when we went to update our new guidelines, we asked the question, what is the evidence for continuing risk after you stop smoking? I don't know why this slide looks like this. And it's too bad. It's a nice slide. What this shows, in fact, is that there is a 10-fold risk, excess risk compared to people who never smoked if you quit smoking after 30 years. Your risk remains quite high. What we also showed is that in the modeling that we did, that this is weird. All right, you see that graph there. What we're trying to show with that graph, I'm not sure how it shows up there, but What we see is that the lung cancer risk flattens out a bit. But after 20-pack years, in other words, if you have a long time of smoking, after 20-pack years, your risk is rising by as much as 9% per year with each successive year. The influence of aging takes over and actually increases your risk considerably relative to a person who's never smoked. And what we saw, in effect, is that all of you remember when you were in high school and some of your friends smoked, and they were always trying to smoke in the bathroom for just a few minutes. It's impossible to smoke a lot when you're that young. You have to be out of the house, then you can start smoking. It's very difficult to accumulate 20-pack years and quit, and have quit 15 years before the age of 50. It's heroic, in fact. So that means that most people who would be eligible for screening can start screening. But what this graph shows is that once you've started, according to the task force guidelines, you're going to lose eligibility pretty rapidly. And so we are disqualifying over 4.5 million people from lung cancer screening as they get older. So when we increased, and when our guidelines increased the number of people eligible for screening from about 14 million to 19 million, we did not create a new group who was eligible for screening. We retained a group that was originally eligible for screening. Now, in terms of the pack years, what we also have seen is that women and racial and ethnic minorities have lighter smoking histories. And so studies have started looking at the proportion of people diagnosed with lung cancer who weren't eligible for screening at the time of diagnosis. This is a paper by Melinda Aldrich, and as you can see, these the African Americans, the Black adults who were diagnosed with lung cancer, and this was before when we still had a 30-pack year history. Look at the size of that number that would not have qualified for screening. These scatter plots, in effect, show a similar thing where you see that everybody that is outside those two lines are people who would not have qualified for screening. And you see the same thing with these charts. Is that what I've shown you with the highlighted green there, those are the people who would qualify, and everybody outside of those scatter plots do not qualify for screening. So the point is here also is that what we're seeing is that if we just look at duration, if we dump pack years altogether, we achieve parity in eligibility and much greater inclusiveness in our eligibility for lung cancer screening than having to flail about and trying to estimate pack years. The last thing I'd like to talk about is multi-cancer early detection tests. So, and I'm sorry, I have no idea what happened to these slides because they looked fine this morning. Roughly 60% of deaths each year from cancer are in cancers that we cannot screen for. And so the potential of a multi-early detection test is that you would have the opportunity to screen for many cancers at once because they have a common signal. And that some of the tests actually have pretty successful ability to identify the origin of the signal and zero in on a cancer to diagnose. Others would send you for imaging with a good idea of which cancers probably gave you that signal. But it provides an opportunity, potentially, if it turns out to be efficacious, to really revolutionize, be quite a game changer in our ability to screen for all those cancers that we presently don't have cancer screening tests for. And the likelihood of having cancer screening for these tests within our lifetime is very low, given the cost and the duration of running that many individual randomized controlled trials. I'm going to stop here in the interest of not having you try to decipher the remainder of these slides. Right now, the NCI has launched a pilot study called Vanguard to determine the feasibility of doing these large trials. The National Health Service in the UK is doing a very large study evaluating the outcome of a large population group undergoing the GRAIL test. There are other studies underway, but the challenge we face right now is to determine, in a setting where these tests are being developed by private industry, how we can maybe learn from the methods that we've used for the last 4 decades and get a faster answer to the efficacy of these tests than we will by doing business as usual. So thank you for the opportunity to speak with you about new developments.
Yeah, we're going to move on. Okay. So thank you, Dr. Smith, for your leadership and for ACS's leadership in screening, which is important for moving the field forward. Kelly?